Welcome and good evening to this webinar. My name is Matthew Garrett and I'm the Dean of the Royal College of Surgeons, the Faculty of Dentistry of the Royal College of Surgeons of England. I'm joined this evening by my four other dental deans of the United Kingdom and Ireland. And at this point in time, I would like each of them to introduce themselves, please.
Hi, thanks Matthew. My name's Andy Edwards. Good evening everybody, it's nice to be here again. I'm the Dean of the Faculty of Dental Surgery at the Royal College of Physicians and Surgeons up in Glasgow. My day job is an oral and maxillofacial surgeon, so I can maybe try and give you a bit of an insight into what's been going on in possibly secondary care. Thank you, Matt.
Thank you.
Hello, good evening everyone. My name is Albert Leung. I'm the Dean for the Royal College of Surgeons in Ireland, Faculty of Dentistry. My day job, I'm a Professor of Dental Education at UCL Eastman Dental Institute. Thank you.
Thank you.
My name is Ian Mills. I'm Dean of the Faculty of General Dental Practice. I'm a partner in a mixed NHS private practice in North Devon. And tonight, Matthew, I've come dressed as a dentist.
The only one who actually looks like a dentist tonight, so it's good.
You wouldn't have said that if you'd seen me 10 minutes ago.
My name's Philip Taylor. I'm the Dean of the Faculty of Dental Surgery of the Royal College of Surgeons of Edinburgh and a recently retired Professor of Prosthodontics and Honorary Consultant in Restorative Dentistry.
Thank you, Deans. We're also joined this evening by the Registrar at the FDS RCS England, Hazel, and Hazel will be fielding the questions to us as they come through on the chat a bit later on. So I think it was a useful thing for us to reinstate these webinars. As some of you will be aware, we did this over the course of the summer, then we stopped a little while, but we think that at the present time there might be some more questions that we might need to help with or to answer, or to, in fact, if we don't know the answers to some of those questions, to be able to field those questions to various organizations who we have contact with, and then we can get back to you. So it's great to hear from fellows and members about your concerns and questions that you might have. We all know that we're working in a brutal environment actually within the profession at the present time. And as I said, we're here to help update you on the various issues that might be pertinent to your particular practice, or concerns that you have regarding education training that we can perhaps answer and help you with. I think the whole profession, and all of the deans were talking earlier, everyone is working exceptionally hard, and I know that all of us are encouraged by hearing about the ways in which our particular members and fellows of our various faculties have adopted to the call for help within dentistry and also in the wider pandemic. We've all seen many examples of, flexibility, creativity, and a can-do mentality within our members and fellows. So I think on behalf of all of us, we just want to thank you for, all the exceptionally hard work that everybody has been doing, and to keep it up as well. So I'm going to ask Hazel if there are any questions that have come through onto the chat so far, and obviously do field your questions in. The more questions that you wish to field, we'll be very happy to answer them as the course of the webinar goes on.
Yes, we've got quite a few questions. Some were sent in advance and some are coming in on the chat. The first one we've been asked is, how reliable is testing?
Andy, would you like to kick us off?
I'll kick off with that. Yeah, thanks for that one, Matthew. Yes, just to reiterate what Matt said, I hear so many fantastic stories of our profession and how they've risen to the fore over the last, well, year now, really. And little did we know that we'd be sitting here 6 months down the line after we'd done these first Q&As, that we'd be here again in the midst of another storm, basically. So here we are. But yes, testing, how reliable is it? Well, obviously we know there's two types of testing. There's the PCR testing, the polymerase chain reaction testing, which is highly sensitive and highly specific. And the one I think that people are alluding to is what they call the lateral flow testing. I'm subjected to that twice or three times a week in my day job, and I've got to do it tonight. And the problem with this test is it's not highly sensitive, and this is the problem we have. It's a lateral flow test, which basically when this test was evolved, the Public Health England, I think, looked at over 1,600 lateral flow tests that were available on the market. And the one they went for was one by Innova. And this is the one that they've evaluated using the port and down arm of it. And I think the University of Oxford had a look at that. And it was particularly used for care homes. And they showed that the sensitivity of it was around about 70 to 80%, basically, which it generates a number of false positives and indeed false negatives, which is not good. The next biggest study, if I remember rightly, it was shown was in Liverpool, where find Liverpool used it quite significantly, and they were able to get their tier down from tier 3, I think, down to tier 2. But again, the Liverpool study showed that the sensitivity of this test was in the 50s, which is very, very low. The problem you've got is it's twofold, really. Is when you do the test, the test basically testing shedded virus, and the virus it's actually shed. So you've got to be highly infectious about it. Now, the problem with that, there's no internal control mechanism for this test. Basically, you take a swab, you stick it up your nose or in your mouth, or saliva or mucus, you mix it with a buffer solution, and you put it on a plate, basically, which is very like the pregnancy test is a lateral flow test. You wait 20 minutes, or they say half an hour, and you'll get either a negative test or a positive test. Now, all that's telling you is you're being positive for virus. It hasn't actually got any internal control mechanism, i.e., is there human tissue in there at all? All it's looking at is virus, basically. So there's no internal control for it. So that's the problem with lateral flow tests, is they're not very reliable. I mean, thankfully, I've been positive so far in all the tests, but again, I don't know how many of that has been a false positive or false negative. So if you look at it, the overall sensitivity is 70 to 80%. However, again, that dropped remarkably down, particularly if you're trying to do it yourself. That drops down to about 50% as well, because if people try and stick a swab up your own nose or your own throat, it's very, very difficult to do. So reliability, not very good.
Thank you, Andy. Any other colleagues have any comments about lateral flow testing?
I think all the tests that you have got a certain degree of sensitivity and specificity. Nothing is 100%. As far as the lateral flow test is concerned, the advantage it has is the time from where you have the results after you've actually performed the test. So at least there, in cases there where people are not showing any symptoms, there are chances that they are being picked up. And I think that if you look at it scientifically as a test to say that, wow, it's a definitive test, no. If it is used as a test for the purpose of, say, picking up people on the population who are asymptomatic, who may be spreading the virus, and to stop them from doing so, it may be effective to some extent because of the limitation in sensitivity and specificity. I think that serves its use, as opposed to the PCR tests itself there. I mean, the PCR test itself there is a lot more accurate itself. Sensitivity and specificity is a lot higher because the polymerase chain reaction through the DNA sample amplification is highly effective, because I think read that the 3 stages, the denaturization stage is very, very sensitive. And then the synthesis stage, which is stage 3, blowing up the DNA, is again sensitive. The problem there, of course, is time, costs, and obviously there's no control over that. You're going to swab in the back of the nose is very, very uncomfortable. So each of those have got its own advantages and disadvantages. It's better than absolutely nothing for obvious reason.
Thank you. Ian.
I think I would reinforce what Albert and Andy have already said. It's about weighing up the pros and cons of doing this, and I guess the two main concerns that I have in practice is that how quickly we are able to rapidly access a PCR test to confirm a true positive. Because if we aren't able to do that, it can potentially take people, and this is not just in general practice clearly, but there are concerns about that, about how quickly can we access a PCR test that is more reliable. It's still, I mean, I think we all appreciate it's still not 100% reliable, but so that's one concern. And my other is that the message that we can potentially send out with getting a negative test, and that even if you do have a negative test, it would appear that the sensitivity of it is very much related to the viral load. So the number of the studies, the Liverpool study and the Birmingham study, showed that it missed a large number of individuals who were asymptomatic carriers, but it just didn't register. And there's then concern that if we think we're negative, do we then relax some of our protocols? Maybe not deliberately, but just subconsciously. So I think a message we definitely need to get out there through our own organisations, through the BDA, through Public Health England and others, is around the fact that a negative test doesn't mean to say you can relax your current protocols.
No, that's very helpful. Hazel, are there any other questions that have come through?
Yeah, one that actually follows on from that quite well. Should patients with a negative PCR in the last 72 hours be treated as a low-risk patient with standard PPE?
Well, my understanding is that provided the individual has self-isolated since the time of the test, then they can be treated as a normal patient without standardized PPE. I think that's my understanding of the guidance. Any other? Ian's got a comment.
Sorry to jump in. That was a concern that was raised at a recent SDCEP meeting.
Okay.
That if we go back to October, I think the IPC guidelines that were issued by PHE, and there were specific dental ones,
Yes.
categorised patients into high, moderate,
Yeah.
and low.
Yeah.
And I think in the low risk category, it stated that if they had a negative test, that they could be treated as low risk. And I think what we need again is just clarification of what test that is talking about, and reinforce the fact that it should be 72 hours isolation clearly, because we could have another discussion completely about PPE and the need to be wearing enhanced PPE and what the risks are. But as it stands at the present time, I would have serious concerns of someone that had a negative test, lateral flow test, for instance, because people are getting these within their own workplace, and they presented, and we then decided to treat them as low risk. So I think there needs to be clarification around that.
Yeah, I agree.
And what test.
Andy.
Just to jump in, yeah, I mean, in hospital practice, it's risk and stuff like that. And we would normally, I'll say, for example, if it's a patient who was a low risk patient, we'd have a PCR test done at the hospital and self-isolate for that 72 hours completely. And they'd be categorised as going on what we call a green pathway, as long as they hadn't come any contact with anybody. And it was a PCR test done in hospital with a negative result. In 3 days, they would be classified as going on to what we call a green pathway, basically.
Yeah, I think that's my understanding of the IPC guidance as well, Ian. But yeah. Phil, do you have anything to add?
Well, not really, except there's a level of trust involved with this, isn't there, about people and self-isolating. And I think this goes to the argument about you go to the supermarket and you watch folk walking around without their masks on. And I think there's a level, if you're in general practice, that you've got to actually understand your patients, and I think you probably do know that better than you would do with a hospital patient. And it's difficult to say, oh yeah, I trust that patient or I don't trust that patient, but it's your own safety and the safety of your staff that become very important. So I think there's something beyond guidelines and regulations and whatever. It's a matter of what you feel safe for you in your practice.
Yeah, no, yeah, that's helpful. Hazel, anything else?
Yeah, will vaccination of dental clinical staff allow us to return to normal?
Who wants to answer? I won't pick on anyone.
I think the answer to that is that possibly, but there are a lot of caveats on it, because even if you have been immunized, whatever the Oxford vaccine, the Pfizer or Moderna, or whatever vaccine that there is still no evidence to suggest that you will not be infective, that you will not pass on the infection. It's just that you will not suffer from any serious illness. So you should observe the same protocol as everybody else would do. The fact that you might not fall ill doesn't mean that you will not pass on the virus. Somebody else would fall ill. So that's the caveat. And also, how long would the antibody level stay up for? We don't really know. Would that be the CD4 T cells count and CD8 plus T cell count will stay up? We don't know. We've only known the virus for 9 months, so something else can happen in that period of time. So just take precaution, I would say, like everybody else.
I get absolutely what Albert says. I mean, a vaccination is not a panacea for let's go out and enjoy ourselves. Basically, you can still be transmissible. All the vaccination does is you enhance your own internal immunity to the virus. So any symptoms you have are liable to be less significant and possibly not end up hospitalizing you, but you still are you can still transmit the virus even though you are vaccinated, because as we know, everybody's immune system responds completely differently. We get good responders, we get poor responders, and that's been shown with things like the hepatitis vaccine, which has been out for years. Some of us are very good responders. I was a particularly poor responder to that, so there are various as well. I think an interesting question, probably Ian might be able to answer this, is you know, the vaccine is not compulsory. So do you make all your practice staff have the vaccine? Can you do that? Can you impose them if they're an anti-vaxxer or something like that? I don't know. It's a very difficult one, and you're getting into a lot of difficulties with employment law and stuff like that. I don't know if Ian's crossed that particular bridge yet.
We haven't, excuse me, cough I've just developed. We haven't encountered that within my own practice, but I certainly am aware that there are many discussions going on about that. And within the General Dental Practice Committee, the BDA, I know that discussion has been had. I think the view is that at the present time, no, it's not being treated like Hep B, and it wouldn't, staff wouldn't be obliged or forced to take it. I think the responsible decision is to sit down with our staff, our colleagues, and talk about not only the personal responsibility, but actually responsibility to colleagues, to the wider community as well, and try and put forward a cogent argument that you know, this is for the greater good and why we should all get vaccinated when it's available. So, but no, I haven't encountered that personally as yet. In North Devon, the vaccination has arrived, but the programme hasn't quite been rolled out yet. But hopefully it will be soon.
Can I just say something a little bit?
Yes.
If you think about the parallel with the flu vaccine, it's the same thing. The hospitals have not been able to force members of staff to have the flu vaccine. What they have said is that you have to sign an affidavit, if you like, to say that I have refused the flu vaccine. So it's a very different thing. I don't think we're ever going to be able to make people actually have a vaccine of any sort, but there may be something where we're actually saying you have specifically said you're not, so they can't come back and sue you if they get COVID and die. I think there's probably something there. Whether that would stand up in a court of law is another kettle of fish, I think.
Thank you. Hazel, is there anything else on vaccination, perhaps?
Yeah, someone's asked why the profession isn't being fully utilised deliver vaccinations, having tried to volunteer their practice and not received a response?
Can I answer this one?
Yes,
Yeah, this is a bit of a hobby horse of mine. That Matt and I go on to a meeting every Tuesday with Dr. Powis, where I offered the dental hospitals as a potential place to have vaccinations. Because if you think about it, the majority of the standard dental hospitals have about 70 chairs in them. Some of the smaller ones are 20, 25, and even then, a lot of the dental hospitals have got outreach centres of 20, 25 chairs. We have a whole gamut of late dental students who would be in final year or in fourth year who are more than capable of giving vaccinations. One of the problems with the dental hospitals is that they can't see the patients because they're having trouble with finding space and with aerosol generation. So actually it would be a good thing for them to actually do that. They were interested, but never actually got back to me over how that could be managed. So I too am disappointed that that's not happened. One of the problems for general practice, I understand, is that to become a vaccinator, you have to have done some of the mandatory training that's expected of a hospital consultant. So there are some of the things that might seem nonsensical to a general practitioner that they're being expected to do, and they may not have access to be able to do those courses and get that mandatory training. And there's a whole list of stuff that would be commonplace for a hospital consultant, but it would be alien to someone in general practice. And I think that's where one of the problems has been. There's not enough flexibility. The strange thing is that they're training all sorts of other people in different professions or non-professionals to do it, and it's makes a mockery of it. So there doesn't seem to be a rule here.
Yeah, I mean, I think there are a lot of people that have come forward to be vaccinators. That's my understanding of it. That there's a lot of volunteers that have put themselves forward. I suppose part of my anxiety in some ways is that there is a fair bit of essential dental care out there still to do, and the students would have to attain certain competencies as part of their undergraduate training. So one doesn't want to completely deflect away from that, I suppose, in some ways.
I think, Matt, I think there has been quite a bit of local, regional, national variation even. I'm aware of colleagues who have got involved in the vaccination programme already. I'm aware of many colleagues who have volunteered and have waded through the red tape to the other side and have volunteered but haven't heard anything as yet, and others that have given up at the first hurdle. So I think we're going to see that anyway. Across the profession, there'll be some who are very keen to offer their services. Others perhaps feel that they've got other priorities at the present time. But again, I think the profession have done admirably in pushing this agenda to say, look, we have got certain skills that are transferable. We are keen to help, a bit like back in the first lockdown with redeployment, where we had so many people step forward. It's slightly different now because of the other clinical commitments that we all have. But I guess what we need to be is just standing, be there in reserve, and when we're needed or called upon, that we do step up and help.
Yeah. I personally, I did volunteer to be a vaccinator at my local GP practice, but they didn't get back to me. So that's a story that we hear quite often. So yeah.
Likewise as well, I'm off on leave this week, and I've got a lot of leave to take, so I offered as well. They've just opened a vaccination centre at the local Blackburn Cathedral, which is not far from me. So I volunteered not to be a vaccinator. I said, look, I can make cups of tea, I can show people around, I can hold somebody's hand if they're needle phobic, or just talk to them or take consent. So but likewise, I'm still waiting to hear back from them as well. But as I say, it wasn't to be. But I hear what Ian said. I did look at the amount of red tape you would have to go through, and even being a hospital consultant, where I'd sort of ticked a lot of these boxes, I still hadn't done things like moving and handling courses or fire safety course or something like that. It was just ludicrous, and I think Hancock actually appreciated that when somebody actually showed him the booklet of about 20 odd pages. He said, maybe this isn't right. Basically, I think just health and safety went a little bit OTT.
Yeah, I agree. Okay, thank you. Hazel, anything else on vaccination issues?
Not exactly vaccination, but around infection control. When are the faculties going to challenge the lack of clinical evidence for fallow time, aerosol and enhanced PPE, and hence a return to normality and patient care?
Andy, Ian, actually.
I think that is happening already, and it's to be welcomed, because we do need to be challenging where there isn't evidence. We ought to be driving that agenda forward where we need evidence to underpin what we're doing, to demonstrate that it is safe and that it is proportional. And I was at a meeting with the SDSET group last week, and certainly there were discussions around that. Are the current infection prevention controls, particularly around PPE and fallow time, appropriate? Are they proportional? And I'm sure that is something that will be investigated and explored in much more depth over the coming weeks and months, because clearly it has a massive impact on the delivery of care. It also has a massive impact on the human factors aspect. It's not pleasant to be wearing FFP3 masks and gowns and trying to do quite intricate procedures. Not that I do particularly intricate procedures, but I think that is a real concern, and it's something that we mustn't just accept that as the norm going forward. And I think there's a responsibility on us as a profession to keep challenging the evidence that's there. And I would reassure the questioner that that is happening, perhaps not at the rate that some people would want it to, but it is happening.
I think you're doing yourself a disservice, Ian. I think from where we had our last webinar with the deans, I think, when nobody had hardly ever heard of a fallow time or anything like that at all, I think we've done absolutely fantastic in the research. There was hardly any, there was no research out there. And the amount of work that's gone on with both all the faculties, FGDP, SDSET, and a whole host of the other dental associations have all contributed to some very, very, very good guidelines and looked at it, because when we first started this, we were scrabbling around and we were reading papers way back from the 80s and the 90s on droplet infection and stuff like that related to flu viruses, and we were trying to transpose this to COVID. But I think where we are, it's still evolving. You're absolutely right, Ian. It's still evolving. We've come a long, well, as the song goes, a long way, but I think we've still got a further way to go yet. And as I say, but as I say, the research, and there's been a lot of research that's gone on. Some have been very, very good. Some have been, well, yeah, not so good, basically. But that's the problem with research at the moment. But I still think it's rapidly evolving, and we have gone a significant way to try and address a lot of the concerns that the profession had at the very, very beginning of the pandemic.
Yeah, I mean, I think absolutely, Andy, I would echo your comments. I mean, this is a novel virus. We haven't got any randomized control trials, and I do think that it's about mutual responsibility, I suppose, to make sure that we all are collaborating with each other and making available to each other any new evidence which arises. And I think that's what it's about at this point in time. Thank you, Hazel. Anything else about vaccination on the or infection control?
Infection control, an interesting and very specific one. What do we do if we need to have an interpreter in the surgery, as the interpreter will not be from the same household?
I mean, you could use a telephone interpreter, I suppose, at a push. That's what I would suggest, rather than bringing another body into the surgery. Just from the top of my head, I would say use a language line facility rather than an actual body if you can.
Yeah, we've had to use that in the hospital, Matt, a couple of times. We've had patients. I think the last patient was Romanian or Eastern European, couldn't speak any English, and we have a process, we have a language line where we can have the patient on and through a speakerphone system. So that's probably the easiest way to do it, rather than actually involve a third party, somebody who's out with your bubble or potentially a transmission risk.
I think that would be the safest way.
Yeah, I mean, it's just like the system where if you are in, say, the airports and some interpreters are required very, very quickly, they don't have an interpreter brought in physically. It's through the telephone or through other means of communications, so that the interpreter can function very, very well, in this case, outside the bubble. So I think that would be a good thing to do. I was agreeing with Andy and Matt completely.
Ian, you had a comment.
No, I think that seems a very sensible way forward, but let's not lose sight of this. You know, you have to make a risk-based decision, a risk assessment, and you know, I appreciate the rates of COVID in certain areas of the country are incredibly high, and there are significant risks. But there are ways that we can mitigate against these risks, and there will be situations where you have to, assess that, and if it's in the patient's best interest and the interpreter is happy, and you can mitigate that risk through wearing PPE or whatever, then that would seem sensible to me. But there will be some situations where it might be difficult to access an interpreter, and it's just just weighing up the risks, the benefits, and the risks.
Mm-hmm. No, agreed. Thank you, Hazel. Anything else?
On that topic, not at the moment. There's a fair bit about training. Can I move on to some questions about training?
Let's move on to training.
Right, I'm seriously thinking of sitting the exams with the colleges. Would the deans advise me to go ahead with my plans, or would I be better off coming back next year when we're back to some sort of normality for training and education?
I think we'll all answer this the same way, but let's start with Andy. Phil seems to have paused.
All right. Maybe he's decided it. But no, I mean, it depends which stage of your career you're at. We're talking about, I mean, you mentioned membership exams. Are we talking specialty membership exams? Are we talking MFDS? Or are we talking exit member fellowship style examinations? I think all the colleges have risen to the fore, and we've been under significant pressure, not just in dentistry, but in surgery and in medicine as well, to be reactive and proactive as well about how we deliver our examinations. And we have tried to we've had to cancel the examinations, but we've tried to deliver them, and some of them have been delivered in an online methodology. I personally would think try and continue on as normal. We're trying our best as colleges to deliver our examinations to our candidates. We know it's had a huge impact as well on people's careers and career progression and career enhancement. We find that some of the exams are not necessary for career progression rather than enhancement. But what I think we would all say is just continue as per normal. We will try our best as colleges to provide the examinations. We appreciate that we may not have to cancel them. And again, just with this second or third spike, if you want to call it as well, has had another huge impact, not just in the dental arena, but in the surgical arena and the medical arena as well, where a lot of exams have had to go down. But we are looking at novel ways of trying to deliver them, so we can keep careers going and keep careers being enhanced.
Yeah, I mean, at the start of the pandemic, we were obviously we had to get ourselves a bit organized in order to change the delivery mode of some of our examinations. But I think everyone has as Andy says, risen to the challenge really well. And the exams departments in all colleges have worked extraordinarily hard to transform the delivery methods of the exam. So, I guess on behalf of all of us to thank you all for your patience, and the exams teams as well for doing what they've done for us. So yeah, I wholly support what Andy said. I don't know whether Phil or Albert have got any, or Ian have got anything to add.
I think one of the key things is that we've got to make sure that whatever we do as an alternative exam is not a lesser exam outcome than we have previously. So it doesn't mean that whether you had a face-to-face exam or whether you had an online offering, that should be any different. We don't want people to think that they've got a COVID examination. They've got it's got to be the same thing. The qualification has to be the same. It has to cover the whole of the blueprint, and it has to be a secure outcome for patient safety, which is actually really what we're measuring with these examinations. So I don't think it matters to this person whether they take the exam now or they wait. It may well be that there will be a hybrid of online offerings and face-to-face offerings in the future, but it may well be that a lot of these examinations will remain online after, because actually there are some good reasons why that might be the long-term future for some of these examinations, especially international exams.
Yeah, no, agreed. Albert, do you have anything to add?
Yeah, I would just say that to colleagues who are thinking of whether to do any assessments or not, it's just like a car. If the car has come to a neutral gear, it's very, very difficult, more difficult to start from a neutral gear up to the first and the second gear or the third gear. But if you're in the first gear all the time, you can move up much quicker. I think that's something to do as far as training is concerned as well. As far as assessment is concerned, there are alternate assessments, examination strategy, which all colleges have adopted, so that the same learning outcomes, same blueprints can be assessed in alternative way, which is equally valid. We are all learning, including people colleagues who are sitting in the exam as examiners, because we've never experienced anything like this before. But we're all striving forward, and alternative ways of delivering assessments have improved hugely in the last few months compared to what we were, say, a year ago. So colleagues should have confidence in sitting our examination with all the colleges that we maintain the standard, maintain the delivery, and there's no compromise on it, albeit in a slightly different manner itself. So carry on, go on with it, and we all do our very, very best to accommodate those as well, I think.
Thank you. Hazel, is there anything else?
There are a lot of people asking about fifth-year undergraduate dental students and the lack of clinical training that they're fearing that these people are getting. And someone said, what would you advise a newly qualified dental student who doesn't feel ready for practice?
Ian, do you have any suggestions to the underexposed dental graduate, I suppose?
Well, I guess I swing from one side to the other in terms of this, where I think, goodness me, when I was a fresh-faced graduate, which is hard to
Wasn't
believe,
that long ago, surely.
I was incredibly ill-prepared in certain regards. And I think we have moved on considerably in terms of our understanding of education, of the support mechanisms that are in place for a young graduate in terms of dental foundation training, dental core training, access to postgraduate education, CPD. And although there has been criticism in the past of some of the clinical experience that some of our young graduates have had, I think their attitude towards training and embracing further education is excellent. And I think we just need to make sure that there's a support mechanism around them, access to mentorship. We don't put unnecessary pressure on them, particularly within the NHS, to strive to knock out large numbers of UDAs when they come out post-dental foundation training. And what we're trying to do is just support them, get them to be able to identify the shortcomings through a PDP, and then give them access to the courses and the support they need. Yes, there are concerns, and I'm sure there are individual concerns for some of these young graduates, but it's up to us as a profession to give them a safe environment to help them develop their skills. And I think that's a much safer environment in some regards than when I came out, although I appreciate that it's a much more litigious environment that we have nowadays. So there are things that we can do as faculties and colleges, things that we can do through higher education institutions, and also perhaps things that the GDC can do as well to help give confidence to these young graduates to come out into this working environment.
So did you qualify before VT was mandatory?
I did, yeah.
Yes.
But interestingly, as you know, as some of you are aware, that I qualified from the greatest dental school in the UK and Ireland and beyond, and our knowledge and experience of exodontia, removal prosthodontics, oral medicine was excellent. Perhaps not so in the restorative perio and ortho, perhaps. But you then understood that, and I think as a responsible young graduate, you identify where you have to target your PDPs. And
Yeah.
I think I trust many of the young graduates to come through to be able to do that.
Yeah, I think you're absolutely right. I mean, I actually qualified when VT was mandatory. So not that I'm gloating to be the youngest dean on the panel, but I do think that, you know, it's really important that a dental graduate is entered into a very protected environment, as they are with foundation training. And actually, when Hazel was reading the question, I wrote down personal development plan, and I think that's what it's about. Just, you know, highlighting the weaknesses, the strengths of an individual, and working with them to make sure that they do feel that they're confident and competent to pursue what they want to do, essentially.
I completely agree, being one of these old farts as well, like Mills there. One day you're a student, the next day you're a dentist. There was no sort of bedding in period. But I think you've hit the nail on the head. I wrote down PDP as well. I think we're all singing from the same hymn sheet. I think we've got some fantastic trainers out there. The guys out there who take on these very young dentists, I think, are fantastic. They're very supportive, and that's another word I picked on, as a supportive environment as well. The GDC as well have to be involved with these guys when they come out. These youngsters, when they come out, they have to make sure that they are supportive and they strive. And there's going to be a degree of anxiety. In fact, a significant degree of anxiety for the young graduate who goes out there into dental practice, and it's identifying where and their shortcomings are, if there are shortcomings, and being able to support them. And as colleges, as faculties, as individuals, really, we should be very, very mindful of that, because there's a significant degree of angst out there amongst all these undergraduates who are coming out. When I was a lad, it was just you got on with it, but we don't do that these days.
We won't ask where you graduated from.
Much better one along the east coast from Mills. Yeah, as I say, it was the most.
I would just say that Andy and myself qualified from the same dental school a couple of years apart, so that's all the clue that is there. So completely agree with what Andy said on that. Completely agree with the experience there at the time, which is completely different from what it is at the moment. But strangely enough, I wrote down exactly the same thing, that personal development plan, because the mentorship and the help and the guidance that a mentor can give to a young, newly qualified dentist is tremendous. And the amount of escalation of skills, acquisition of skills, decrease or increase in competence and confidence throughout that year is absolutely crucial. I think that's very, very important not to lose sight of, that the skills escalator starts there and then whenever you qualify. I think it is important, of course, that legally speaking, a qualifying dentist or dentists who qualify need to have had all the skills and learning outcome of GDC required by law for registrations. So the next point that I have on there is that this is the advantage of a foundation training. From the constituency part that I represent in Royal College of Surgery in Ireland, in Dublin, the Republic of Ireland has no dental foundation training at all. So when you finish with your dental degree, which is completely compliant there with the European Union there, you are out in the code, you are out in practice. So just think of those colleagues who qualified in Ireland, who practice in the Republic of Ireland, who are newly qualified, what the state of mind and what the state are, because they are straight into the code phase. You may not have a mentor scheme, you may not even have employment, you may be underemployed, and there may be lots of issues with training. So it almost come in and say that, look, it is a good idea from the educational point of view. Of course, the politicians and others may decide otherwise, but from a pure educational point of view, there a scheme very, very similar to that of Dental Foundation, will be very, very desirable in the Republic of Ireland as soon as practically we possibly can, in order to guide the professional developments of young colleagues qualifying.
Thank you, Albert. Hazel, any more questions about training?
There are a huge number, but there's some very pressing questions coming in about the impact on oral health care and about safety, and I'm conscious of time. So I wonder if we could come back to training if we have time.
Well, maybe we can put a Q&A sort of answer session on the websites of the individual colleges. So we've answered some of those other questions that we haven't had time for. Yeah, so let's move on to safety. I think that's a good idea.
Right. First question, which has been asked by quite a few people, children and vulnerable adults who need dental treatment under general anaesthetics are facing huge waiting times, with backlogs increasing due to COVID pressures. How can this be managed?
Andy, do you want to speak to that?
It's working in a unit where I have special care dental colleagues who treat vulnerable adults, and I have paediatric dentists as well who treat children. There's been a huge pressure put on us. We've unfortunately had to, well, as you probably well know in the press, we had an area where we were probably about 4 weeks where we didn't carry out any what we call elective treatment. We had a lot of children that were attending in extremis, and I was ended up having to go in as a consultant maxillofacial surgeon to take out baby teeth on youngsters who presented with dental facial abscesses from their decayed D's and E's. I know my dental colleagues have got a huge amount of kids on their waiting lists. Our trust is trying desperately to get these patients through, but it has made a huge impact on the trying to deliver the care that they are. I know my colleagues are actually coming in at the weekends now and actually doing lists on Saturdays, and probably they would be trying to come in on Sundays as well, just to try and get in it, because the problem we've got is we've, again, and particularly in my trust, we've cancelled all our elective work. Everything's been categorised in category 1, 2, 3s and 4s. 3s and 4s can wait 3 months, it can wait 6 months basically for the treatment, and that's what's happening with a lot of stuff like dental alveolar case and a lot of children's dentistry as well. They are trying to prioritise them, and I know my dental colleagues meet on a weekly basis with the managers to try and do that, and I know a lot of other hospitals are doing that, but there's a significant increase in the waiting lists at the moment. I mean, I can talk that my waiting lists are pretty huge within just routine stuff. We're unable to do any routine stuff basically, and this is having such a knock-on effect to children's health basically.
I think. Go on, sorry, Phil.
I think what we've got to realise is that the largest, the biggest reason that a child is admitted to hospital is actually for dental extractions, and that was before we even started with COVID. London had a specifically bad problem. There are real issues with getting children into any of the hospitals in London to have extractions. There were over 500 children waiting for dental extractions at one time. I can talk specifically between north and south of the river, and what happened was that one of the dental hospitals would have to close their list because they weren't able to see any more patients because it had got so bad. The commissioners decided that that was what was going to happen. That only meant that the patient was passed to the south of the river, where immediately they got overwhelmed and they had to close their list. The north of the river by then had opened, and the patients were just being passed across. The biggest problem that we faced in hospitals, and this was part of my job before I retired, was actually to try and manage this situation, was that unfortunately the hospitals look at dental as a fairly low need value. They're much more interested in getting somebody through trauma and orthopedics are and what I jokingly call the orthopedic juggernaut, where they seem to be able to take over any theatre at any time. And it became a real problem for dentistry, because if they were going to close a list, it was often a dental list that got closed. And that's where we've got a basic problem for dentistry, and particularly for paediatric dentistry. Now, obviously, we can't go back to having extractions in general practice, which those of us who are old enough, and I suspect that I might be the oldest of a lot of you, do remember doing those in general practice. And not giving the anaesthetic, I hasten to add, though, at the time I qualified, you were actually shown how to do that. The patients we saw about 12 patients in a morning in a general practice situation. It's not safe. There are lots of different issues, but we've gone almost from one extreme to the other with patients in a hospital environment. There needs to be a real sit down and look at how we manage these pediatric patients, because I don't think what we're doing is the right thing at the moment. I think we've got a real problem on our hands.
Yeah, I mean, I would. Sorry, yep, Ian.
I was just going to say, and I think Phil just touched on that. If we overlay the impact of COVID on top of that, the burden, the oral health burden, lies with the most disadvantaged in society. And the big concern at the moment is with reduced access for NHS dentistry. The gap within oral health inequality is going to get wider and wider. And this is actually a much bigger problem because, many patients won't have been attending over the last 12 months or so, and these problems will have been compounded. These referrals are going to start coming in. As we start to open up and see more and more patients coming through, there is going to be, I fear, an increasing number of referrals. So this is something that must be addressed, and it goes back again to, particularly, I guess I'm talking about down south in England, flexible commissioning. And in certain areas, we have got the opportunity to deliver sedation techniques for children and for young adults as an alternative for GA lists. But again, there isn't always the support for these services being delivered in general dental practice. And I think that's one of the things that needs to come out of this review of the transformational change within NHS dentistry about flexible commissioning. How can we use primary care to support this existing services in secondary care and take some of the burden off them?
Yeah, no, I absolutely agree with everything, and I think members and fellows should be reassured that whenever we go to any meeting, we are saying the same thing. We are trying our best to make this issue really heard about in all the right circles that we attend in terms of meetings, etc. So we are all very acutely aware of the problems, particularly with paediatric oral health and those waiting for general anaesthetics who may not be able to have dentistry in a normal setting. So it's a good question, and we need to take that on board. Hazel, any more about safety? Because we have about 5 minutes, I think, left. So.
Right, I'll give you these two together then. They're related, I think. Is it still safe to deliver dentistry at the current time? And are current guidelines sufficient when the NHS is at high alert level?
Albert, do you want to say something about, is dentistry safe to deliver at the present time?
Well, personally, I think that depends on what type of dentistry that you're looking at, because routine dentistry is effectively what most dentists would deliver most of the time as such. If you follow guidelines and follow good practice with all the PPE that's required, with air change maybe, following whatever guidelines that you follow there, dentistry, sensible dentistry is actually safe to be delivered. The problem there is that you're looking at the number of patients against the facilities that is available and the capacity that has been for the last, say, few months. It has been drastically reduced. Because of the reduced capacity, reduced ability to deliver, reduced patient attendance, patients may be reluctant to attend for whatever reasons. Even dental staff, they're not immune to COVID, suffering from this, following or self-isolating, that results in a reduction of the amount and type and the quantity of dentistry that can be carried out. And that is manifesting itself because dental disease is a problem that has been a problem. And we see that in adults. We see that in adults, disadvantaged adults. We see adults with high DMFTs. We see children's, pediatric patients, and manifesting itself, and therefore pushing towards a secondary care. So it's like a vicious circle that if the primary cause of it has not been solved, which is difficult, it's going to be pushed behind, it's going to be pushed. One good example is that the number of patients waiting in the waiting list nationally, say even over 18 weeks that I read there, it has gone up from 1,800 patients this time in 2020 to almost about 4 million patients up at the moment. So it is a manifestation of the problem in dentistry as manifestation of the general health. So dentistry is safe, provided that it is done appropriately, but it doesn't still at the moment solve the problem.
Thank you. Any other comments regarding that that question?
I think dentistry. I think we've been well. The answer to my question, the question would be yes and yes. I think dentistry is safe. I think it always has been safe. I think about dentists. We're bloody good at infection control. We always have been. Where, you know, and Ian and Phil will remember the HIV when it first came around as well. You know, people were paranoid about that. We dealt with that, didn't we? We recognised it and we dealt with it. You know, so we were very, very good at it. We've dealt with SARS, we've dealt with MERS, we've dealt with a whole host of other things as well. And as a profession, we are very, very good at infection control. So my thing is yes. We are excellent at infection control, and dentistry is indeed safe. The other question was around about at the alert level. Yes, it is safe. You know, and it's all about. Ian touched on it earlier. There, it's all about risk and risk assessment and mitigating your risk, basically, depending on all the factors that are what the procedure you're doing, whether or not you've got adequate ventilation in your room, and that. And the guidance that's been brought out there is all there to support that. So I do think dentistry is indeed safe. We're doing everything we can to make it safer, and patients should be reassured that any time that they go into the dental practice, whether it be in the primary care or the secondary care, that everything is being done to protect both them and ourselves, basically.
No, yeah, absolutely. Ian, did you have a comment?
Yeah, just to reinforce what's been said already, you know, I think delivering dental services within the guidelines we have at present, it is a safe environment to be doing that. Touching on the point that Andy made about risk assessment, and one of the risk mitigation factors is to reduce throughputs that are going through your practice. And there has been concern, you know, over the last couple of weeks or so down in England about some of the targets within the NHS that are being introduced. And I think one of the factors around that is the sheer throughput you have within an NHS practice is very different generally to what you have within a private practice. Now, to start to increase that footfall or the throughput, there is serious concerns that it's going to impact on the safety for staff and the safety for patients. And I think that's where the discussion needs to be around, is that if we force these targets on ourselves, there is a worry that the sheer numbers going through will make social distancing difficult. It will put pressure on fallow time. It will put pressure on infection prevention control. And I think that's where we are, as a group, slightly concerned.
Hazel.
Yeah, I raised my hand because I've got a couple of questions that have come in just on that very topic. Should we limit dental treatment to urgent care only? And is the imposition of a UDA-based target in England a sensible approach in order to improve access to NHS dentistry?
I think the second one is a bit philosophical, and so maybe we dodge that one for this evening because it's a bit of a wider conversation that I think needs to be had. But I think the first one is, should we just be treating urgent dental care at the moment, is a question that we can just answer before we wrap up. What are our thoughts, guys?
I think both of them are actually bigger questions than you think.
Yeah.
I think what Ian said before is that it's very important that if we're taking longer to see patients, or we're seeing less patients during the day, then you've got to think about whether any of the systems we've got, and actually in Scotland they're still using fee per item, so it's going back to what people thought was a reasonable system as far as a financial situation was concerned, but it doesn't work for the Scottish dentists either. They're not happy with it. So I think there's a bigger thing, and the big question is, what should we be offering on the National Health Service as a dental system? And that's a very different question, and perhaps it's another webinar for another day.
Perhaps.
I'm sorry, I'm sorry to jump in again.
Last comment.
My answer to that is no, we shouldn't just be offering urgent treatment, but we should be prioritising it.
Correct. So it's about, I think it's about, essential care, isn't it? Because, you might fracture your incisor, it might not be hurting, but you know that actually it's going to be causing you a problem. So that would be classed as, I think, essential care. So I think that's the key phrase.
Yeah.
Anyway, what I would like to say is thank you. Thank you to everyone who joined in this evening. I think it's been a lively discussion, which is helpful. Thank you to the panel members, and thank you to Hazel for fielding all those questions. I think we will arrange a Q&A sheet for the other questions that we've got, which we haven't been able to answer. So look out on the websites. Hopefully we can publish that, and you will see the answers to your questions that you've posted. The last thing to say is that the next webinar will be hosted by Ian and FGDP, and it's on the 16th of February, I believe. Is that right, Ian? 16th of Feb. So we'll see you all then. Thanks again for joining, and have a good evening. Thanks very much.
Thanks, Ian. Bye-bye.
Bye.